Hello, and welcome to the webinar. My name is Lily Catalano, and I will be acting as moderator for today's webinar, Adapted Anticipatory Guidance for Infants and Toddlers Experiencing Homelessness, a production of the National Healthcare for the Homeless Council with support from HRSA. This session is being recorded. This publication was made possible by grant number U30CS09746 from the Health Resources and Services Administration, Bureau of Primary Health Care. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the Health Resources and Services Administration. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. To the right of the presentation slide, there is a chat box for participant questions and technical issues. Please type your questions or technical issues into the chat box at any time during the presentation. A selected number of questions will be answered at the end of the presentation during the Q&A session. The PowerPoint presentation and the recording of this webinar will be posted on our website, www.nhchc.org, within 72 hours. All participants have a full screen button located at the top right of the presentation window. You may use this to resize the presentation to full screen, but you will not be able to see or access the Q&A chat below. To enable this view, simply re-click the full screen button to revert to the original view. Thank you. Welcome to Adapting Your Practice, Anticipatory Guidance for Infants and Toddlers Experiencing Homelessness. Our presenters today are Dana Basara, the Dean of Nursing and Allied Health at Grantham University in Shawnee, Kansas, and Lynda Bascelli, Medical Director of Project Hope in Camden, New Jersey. Dana and Lynda are both members of the Healthcare for the Homeless Clinicians Network Steering Committee. Today's agenda will have an introduction, cover some of the challenges and effects of homelessness, some key recommendations of adapted anticipatory guidance, some examples, and time for Q&A and discussion. The Healthcare for the Homeless Clinicians Network is a home for anyone who provides direct service to people experiencing homelessness. We're made up of nurses, social workers, doctors, counselors, community health workers, outreach workers, oral health providers, and any other discipline. We work together to identify priorities in the homeless healthcare field and develop resources to address those needs. If you're not already a member of the Healthcare for the Homeless Clinicians Network, please join today at nhchc.org. It's free, and you'll be joining thousands of other providers from across the country. The Adapted Anticipatory Guidance Project was created by the Healthcare for the Homeless Clinicians Network Steering Committee, who had identified this need after hearing requests from the field. The committee reviewed the American Academy of Pediatrics Bright Futures Standard Anticipatory Guidance and made recommendations for adapting those standards for the condition of homelessness. This fiscal year, the committee has created recommendations for infants and toddlers experiencing homelessness, and then starting in July 2015, we'll begin work on recommendations for school-age children and adolescents. The Adapted Anticipatory Guidance publication is part of a larger series of adapted clinical guidelines created by the National Healthcare for the Homeless Council and available on our website. The written report of this project will be coming this month and will be posted at nhchc.org. I am now going to turn the mic over to Lynda.
Thank you, Lily. I'm really happy to be here. I'm going to talk a little bit about some of the background of this project and start with a quick reminder of how prevalent child homelessness is. This data comes from homelesschildrenamerica.org, and it never fails to stun me when I read that 1 in 30 children in America are homeless, about 2.5 million total, which is an historic high and represents an 8% increase nationally from 2012 to 2013. We can spend hours and hours talking about the causes of child homelessness and their interrelatedness. Single-parent families are among the poorest in the nation and thus are extremely vulnerable to homelessness. Comparing homeless men to homeless women, only 20% of homeless men are in a family compared to 80% of homeless women. Most single-parent families are female-headed. Families experiencing homelessness usually have limited education, for example. 53% of homeless mothers have a high school diploma, and only 29% of adults in homeless families are employed. With limited economic resources and a lack of affordable housing, families can find themselves in a situation with no viable housing option. Additionally, families of color are overrepresented in the homeless population. Nationally, 43% are African American, 38% are white, non-Hispanic, 15% are Hispanic, and 3% are Native American. A history of trauma in homeless women in particular is pervasive. Over 92% of homeless mothers have experienced severe physical and or sexual abuse in their lifetime, resulting in high rates of PTSD, depression, and substance use disorders. We know that impoverished and homeless children are at tremendous risks in terms of their physical health and their mental health, putting them at risk for increased illness, like increased rates of asthma, for example, and emotional and behavioral problems. Developmental delay is more prevalent and may not be addressed early as families deal with other urgencies, and these children are very likely to have witnessed significant violence. Not only is homelessness in and of itself traumatic, the events leading up to the loss of housing are often traumatic for parents and their children and can impact their interactions, marked by stress, anxiety, and loss. Young children may have witnessed eviction and domestic violence. They have lost the stabilities of a personal place and their routines while living in shelters or motels or doubled up. They may be separated from siblings or other family members, perhaps even their parents. Before I started working in healthcare for the homeless and did anticipatory guidance, I talked to parents about whether they had guns in the home, and if they did, whether they were appropriately stored and secured. Anticipatory guidance now is a whole new ballgame. How do I counsel the parent I just saw with her 4-year-old just moments ago on how to talk to their young children about all of the gunshots they'd heard on a daily basis before being moved to a safe house because of domestic violence, about the loss of important toys and possessions, or about the violence that they witnessed? To address the special and unique needs of parents with young children experiencing homelessness, our committee worked on, and is still working on, adapting standard anticipatory guidance goals that are family-oriented, trauma-informed, and that provide support for parents and are resourceful. The recommendations focus on areas missing from standard guidance that are particularly important to homeless health care. Information in the standard guidance is reiterated only to clarify a recommended practice adaptation or to highlight standard practices that are especially critical for homeless families. And now I'd like to turn the microphone over to Dana.
Hi. I am talking about the key recommendations today, and I wanted just to reiterate. A newborn is 0 to 3 months, an infant is 0 to 1 year, and a toddler is 1 to 3 years. If you have a family, a client, recommendation for us is to look at having local resources obtained where you can give direction and resources to parents. You want to know specific housing, where shelters are located, where safe houses are. You want to be able to look at newborn clothing and essentials like diapers and formulas, bottles. And significantly is to be able to talk about the bonding experience with the child, knowing that it's important to hold the child closely and to talk in kind and gentle tones when speaking to the child. And you might want to be able to connect with the parent to let them know that crying and ways of coping are important. Above all, don't take your newborn's crying personally. She may not be crying because you're a bad parent or because she doesn't like you. All babies cry, often without any apparent cause. Newborns routinely cry a total of 1 to 4 hours every day. It's a part of adjusting to the strange new life outside the womb, according to the American Pediatric Society. When you look at the infant, you want to be able to discuss safe physical spaces for the child to explore. When you're looking, you want to be sure that as a child is being able to sit up or you're sitting the child up, that there are no sharp edges for them to fall into or things that could hurt them if they tried to grab. You want to be able to give them the ability to explore, to crawl, to cruise, and to walk. You want to encourage talking to the child. Parents and the ability to be able to talk to their child helps to promote a sense of belonging and encourages the child to listen to words. You also want to discuss safe sleeping arrangements and how it's important for the child to have space to be able to sleep and the parent to sleep. It's not always safe sleeping arrangements, so to make them as safe as possible. You want to emphasize the safety as the child gains mobility, and that's probably one of the biggest components, is allowing the child not to have potential areas that they can be hurt. When you look at the toddler, you want to emphasize that the parent-child interaction is really important. Sometimes the parent is experiencing homelessness and they try to also remember that the child is experiencing homelessness at the same time. If you look at having at least 5 minutes per day of play with the child, teaching them simple songs like the Wheels on the Bus or the birthday song, knowing that if you're going to have the child's attention, lots of times it's to be at their level, to either hold them, sit on the floor, but to be at a level where they can see and respond to you. You want to be able to teach them new words. When you're giving them food, you may want to repeat the food, or if you're giving them something to play with, say what the object is. When you are providing consistency and comfort to the child, they respond to that. Providers can offer parents a local list of child-friendly events and activities. That may well be like the public library in the summertime has story time. You also want to know that many children who are experiencing homeless regress in some areas of development. A homeless child may begin to suck their thumb, or a child who's been potty trained, they may begin to have accidents. And some of this may be reflections on their regression with homelessness. If you look at standard participatory guidance, one thing is never leave your child alone in the home or the yard, especially near cars, without a mature adult in charge. We, as a committee, noted the importance of seeking caregivers at the parent-child trust, and that many parents have friends and family members in their lives that they're not necessarily enjoy the company or of the trust, but they need them in their lives for specific reasons to help care for a child. We need to remember that. Looking at a preschooler, preschoolers are in need of a surrounding that has stability, and you want to be able to know, although housing may not be stable, there can be some things that are going to create stability in the child's routine, like a bedtime or a morning routine, a favorite toy, a mealtime routine like saying prayers or thank you. You want to encourage literacy and numeracy skills, playing with letters or words or numbers with a child, like counting 1, 2, then moving to 3, 4. Exposing the child to books and age-appropriate toys is a way to encourage the child to have also private play and the ability to be able to look at bright colors and objects. You want to discuss physical activity and play is done as safely as possible. Children need to be able to explore and feel safe to do so, knowing that a parent or another loving adult is nearby to return to. You want to discuss the exposure to secondhand smoke, and as Lynda said, you want to know that many children suffer from asthma, and the discussion of smoking cessation with the parent is significant in the ability to avoid the secondhand smoke for the child. And at this point, I would like to turn the mic back over to Lily.
Thank you, Dana. Some other resources we wanted to share with you that are available on the Council's website in the tools and support area regarding children and youth. There are materials on child exposure to trauma, designing developmentally based services for young homeless families, a guide for supporting infant and toddler mental health, and resources on nutrition and fitness programming for families in shelters. These may be supplements to your practice and encourage you to make use of those. As Lynda mentioned, our committee is continuing work on developing adapted guidelines. Next up, focusing on school-age children and adolescents. If you're interested in taking part of that, in reviewing the standard guidelines and making recommendations for how they can be appropriately adapted for families experiencing homelessness, please email me. We would love to have your involvement. And as we've mentioned, this is still an ongoing collaboration, and we would love to have time for discussion here to answer any specific questions you have, and also to hear about any situations or challenging cases that you may see. We'd love to continue the discussion, and you may be able to help inform the next phase of work here. So thank you, Lynda and Dana. I'll begin the Q&A session now. The first question that we received from Heather about special challenges living in cars or tents with children of all ages. How to make this suboptimal environment safe and stimulating for child growth and development. Have you seen any good examples?
This is Lynda. I think that's a fantastic question. When we researched the anticipatory guidance for this population, we did not come across anything specific about living in cars or tents for any age group. How to make this suboptimal environment safe and stimulating for child growth and development is certainly a great question. When I look at what we've adapted so far, I see, the importance of really stressing the stability of whatever routines can make a child feel safe and encourage appropriate development. Right now, I mentioned in my presentation that I saw a mother just within the last hour. She brought her 4-year-old in because her 4-year-old had a rash, but uncovering their most recent history, they were living in substandard housing in a different part of the state where mom was being physically abused by the child's father and had threatened her with a gun and had been abusive in front of the child. So much about sort of the safety of an environment may not have, this family may have been much safer, or this mother and this child may be much safer right now in a car or in a tent than they were actually in that house. But we talked a lot about the child had to leave behind everything. They both left behind everything as they left in the middle of the night, and they're in a safe house right now, talking about, and then they anticipate more upheaval in the next few weeks, how to create something that's stable between the two of them, some sort of a connection, without a whole lot of stuff. And, fortunately, I had this mom really sort of got it and understood where I was going with this conversation. But so many parents have, it's so easy to be distracted by all of the other urgencies that they are dealing with. I was actually, it was lovely to see this mother and this daughter interact in the office, given all that they've both been through, and obvious how much this mother cares for her child. This mom is going to do just fine with this child. And I think we gave this presentation in Washington, D.C., and I think one of the most important things that came out of the presentation was, talking to parents about what they're doing right. There's so many things in their world going on that are just wrong, but focusing on what they can do in a situation is really important.
Thank you, Lynda. Dana, did you want to add anything?
Yeah, I was thinking that in the American Academy of Pediatrics, one of the things that is key to children is to be sure that you have a consistent time that they're allowed to be able to move about, to be able to play, but that recommendation of 5 minutes of play per day, whether you're in a car or a tent, and you bring the child outside into a safe environment, that 5 minutes is optimal time to be able to let the child know that you're loved and cared for. You want to keep them safe. But the other side of it, it allows the parent to continue that bonding experience with the child no matter how old they are. Being able to know that if you live in a car or in a tent, you have the ability to be able to play games, word games, you may sing, but the real meat that you put to the bones is the ability to be able to bond with this child, to let them know that you care for them, that you love them, and you also look at those keys that could be things that you would pick up on. And I think that would be excellent. Thank you.
Thank you, Dana. The next question, do you have any special guidance about moving away from physical discipline to more acceptable modes? how to talk about violence with parents who have grown up with and have to some extent normalized and minimized the effects of violence in their own lives and their children.
This is Lynda again. Another fantastic question. I think looking at guidance regarding physical discipline and violence, so much of what we do with anticipatory guidance, I think, is actually, well, I mean, it's completely counseling parents and figuring out, how to best reach a parent in order to, optimize the care that they provide for their child. So in a situation where parents have been exposed to violence, maybe as they grew up, maybe a mother, maybe she was beaten as she grew up. Maybe she was exposed to violence. The only way to know is to ask, obviously. And I think this is where sort of the importance of taking a trauma-informed approach with the parent makes a difference. My simple and very, I think for me, the most helpful thing to think about when I think about trauma-informed care is thinking about the question, what happened to you? So perhaps exploring some of what the parents, what it was like for them. How did their parents discipline them growing up? And, is that the same thing that they envision now for how they want to discipline their children? I mean, sometimes I think, we've all seen it. We've all seen stressed out parents in our office, and they're trying to talk to, the doctor or the social worker or the nurse, and the child is just being the child. The child is maybe exploring or playing with the, the hand sanitizer dispenser in the room, and parent is distracted by that, and may reach and grab over and pull that child a little back to them a little bit too harshly or yell. And I think that a situation like that opens the door for you to be able to talk about what the parent themselves have been through and how they would ideally like to discipline their child.
This is Dana. One of the things, too, is to always have on hand resource material for the parents, the ability to be able to know that, everyone wants to be the best parent they can be, and having the resources that may be at a specific level of understanding for them, but they also give the ability to parent or role model or give suggestions on how that discipline may be dealt with the most appropriate way, because lots of us want to be able to know that a role model is what we're looking for, and having those resources would help us with that process.
Thank you, Dana. The next question, how do you feel about administering the ACEs questionnaire to gauge adverse childhood experiences?
This is Lynda. Dana, I hope you don't mind that I'm jumping in and answering questions first. I'm assuming that the questioner meant administering the ACEs questionnaire to the parent, but it'd be an interesting activity to administer the ACEs to the family unit, I suppose, whether it's a mother and a child in your office or multiple family members, just to see what the family has been through together. And I think that would be an amazing conversation starter. Again, there are some the timing, I think, would need to be correct, or the timing would need to be appropriate there. It might be a little bit difficult to administer the ACEs survey, perhaps on a first visit. Maybe it's administered piecemeal by different folks in your health center, assuming you have social workers or other mental health folks in your organization. I'd be interested to know if anyone else is doing that right now. We do it for our adult population, but hadn't actually thought about it as administering to a family. Dana?
You may still be muted, Dana.
Sorry. And Lynda, thank you for jumping in. The other side of this is that I think sometimes we forget in organizations that we have lots of people that can assist us in these processes with the surveys. It's a training tool for us to be able to say the more people who have eyes on situations, the more information we can utilize. But the other side of it is that I think what Lynda said is key. You have to do it when the timing is right. And the first visit probably will never be the most significant visit, but allowing the survey to take place as you begin to build that rapport will also benefit the family.
Thank you, Dana. If there are any other questions that you'd like to ask before we wrap up the session, please go ahead and type those now. Next question, which I can answer, where can we download the report when it's available? It will be published to the Council's website, which is nhchc.org. If you also sign up for the Council newsletter, you will receive that monthly, and that will have a notice of the publication as well as a link to the document. And one more question. Did you guys have consumers assist you with the development of the guidelines? We have had consumers involved in framing the project and in giving feedback to the guidelines as they've been developed. We did not have a consumer on the committee developing the guidelines, but that's something that we would like to do, and hopefully in phase 2 that starts in July, we'll be able to do that. And that looks to be the last question, so we will, one more has just come in. What is the best way to approach the inconsistency of care received by those experiencing homelessness? Lynda, you want to address that first?
Sure. What is the best way to approach the inconsistency of care received by those experiencing homelessness? I guess, the first thing that comes to my mind is be the consistency. As much as possible, if your place is the only place of stability for a family experiencing homelessness, then be that consistency. I think about our folks who utilize our services here in Camden, and we clearly have individuals who we serve as the only consistency in their life. A woman who lives on the street near us, who comes in multiple times a day to have her pencil sharpened, and she's endeared herself to all of us, and we'd all do anything for her, but all she really wants is her pencil sharpened. So if we keep letting the doors open, or keeping the doors open for her so she can come in and sharpen her pencils, then that's what we'll be for her. I think if you're available to be that place, just that safe place for that family, I think that might be all that you can or need to do. Any thoughts, Dana? I think Dana might still be on mute.
I'm sorry. I was thinking as Lynda was talking, one of the things that is an important factor is that in your organization, developing processes that bring families back to the center, and it may be an educational opportunity to be able to share. Sometimes it may be playtime for the children, but if you look at that, one key thing that Lynda said was that to be consistent is in offering your availability in every avenue that you have within your organization promotes some consistency, but also looking at those opportunities that maybe you can have educational experiences occur as in-services, or the ability to be able to know that people can come in and just do a coffee day and have kids color, but it promotes and shows the ability to do role modeling.
Thank you, Dana. That will conclude our Q&A session. Thank you all for joining the Adapted Anticipatory Guidance webinar produced by the National Healthcare for the Homeless Council. This webinar will be archived on our website at nhchc.org within 72 hours. At the close of this webinar, you will receive a survey to evaluate this webinar. Please complete it so that we are able to improve your webinar experiences. A link of the archived webinar will be emailed once it is posted to our website. Please visit the NHCHC website for a listing of upcoming council webinars and other educational products. This meeting will now be closed.